Michezo ni furaha, michezo ni dawa. Kimbia na ndoto zako, usichoke wala kuwa. Mwili wako ni gari, akili ni ramani. Safari ya maisha lazima iwe, usichoke wala kuwa. Mwili wako ni gari, akili ni ramani. Safari ya
Okay.
akili ni ramani.
Okay, good morning, good afternoon, good evening from wherever you are joining us from. I hope you had a good afternoon. If you are coming from Kenya, maybe you've already taken your lunch. And if you are outside Kenya, maybe you've already taken a supper or some are sleeping now. So distinguished delegates and technical partners are joining us from across the globe. My name is Collins Dundo, and I am the CEO for Youth Initiative Development Programs. And whether you are joining us from the Ministry of Health and also whichever ministry, and the clinical wing in whichever country that you are coming from, you are welcome to this important discussion. Allow me to take you through the housekeeping rules. First and foremost, all attendees will be on mute, even though you have the unmute privileges, but we ask you to be disciplined in a way. We ask you to be able to unmute yourself immediately when you will be needed to ask question or give remarks during Q&A. And also, this session will be recorded for the institutional synthesis and also for our records. By reminding you this is just to allow you to provide a mandatory consent. And I believe when you are dialing in, there is a prompt that shows that you are required to consent. So to mean you've consented for us being recording this session. Again, the chat box is our house. And also we urge you to make good use of it, introduce yourself, the organization that you come from and the country that you come from. And that will, and also maybe probably your LinkedIn handle so that you connect with the team that have joined us from across the globe. This interaction, we are not going to be many. With the total registration from the people that we've reached out to, around 60. So probably we may have the average good number for having this important discussion. And the theme for today, it's very, very important from changing our field into okay, sorry for that. So before I dive into today's technical triage, let me reflect on the journey we've taken together since we started. Our roundtable one was very one key, that was on training champions of the future. And we identify the performance, well-being paradox, and also we acknowledge that we have been building world-class of stadiums and also world-class of investing a lot on the jerseys, while we are neglecting the psychological component of our African children and the youth. And round two, also we delve on play to protection. We audited together with the experts the financial and the partnership gaps that we have in Africa. And we looked at the potluck model of blended blended finance and challenge the private sectors to move from jersey branding to resilience infrastructure. And the round three touches on the voice on the field. We centered the lived experience, the lived experience of our youth and our children. Yeah, and our young athlete told us clearly, if you are in that session, when the jersey comes off, who am I? So that's $1 billion question, because there is that you who remain. So they ask for an identity beyond the scoreboard. And the round table four, we audited the media, whereby we engaged with the media, sports journalists, and also the bloggers, and we challenged the journalists to move from the scoreboard narrators to guardian of humanity. And together we launched I am a responder movement. So if you are dealing with the youth, you are a coach and you are in this platform, I will advise you kindly just comment, I am a responder. Everyone in the room, if you're a doc, if you are a clinician, if you're a psychologist, just comment, I am a responder. Yeah. So today we move beyond and we move to the final clinical frontier, that is roundtable 5. We have talked about policy, we have talked about money component, and we have talked about stories. Today, let us talk about the referral pathway. I think that's the biggest thing that we really miss and we really lack in our dusty sports fields in our country and even in our schools. So how do we physically and technically connect the red flag on a dusty pitch to professional clinics? So we are currently working and having this engagement so that at the end of the day, we are able to come up with a tool so that we are able to retool the coaches who are the coaches and teachers who are working with the young athletes in school during PE and even after schools in our community sports clubs and academy. So the insights that we are building also help us to revamp and also come up with a roadmap and the content for the Sports Wellness Summit that we'll host in November on 19th and 20th. So, colleague, let us be clear because this is not an academic exercise, but I'll just want you to, we talk from experience and the real issues that are on the ground. So to give a brief of a bit of the statistics, that was WHO report reports that less than 15% of schools have mental health protocols. And also, if you check on the local clubs and academies that we have in our communities, if there is any academy which do have these mental health frameworks and policies, I'll be glad to read it in a comment. If there is, kindly share more about in the comment. So it is a daily tragedy for a child in crisis. To if we don't have that, to mean that we are really moving um, we are really putting our children and our young athletes and our youth who are in sports sectors in a very bad state, because they really strain. We really look at their physical component, but we forget the software, which is the psychological component, which really contributes too much to their performance. So today, let's move from sports clinic to sports club to clinic pathway. So we are here to design standard operating procedures, SOPs, for the experts who are in the house. I know you understand what that really means. For the coaches, I think it will be broken down and you'll be able to understand it. So we want a coach to know that if they are a player they have a player who, for example, withdrawing or acting out. So they have a roadmap to get that player to probably Dr. Shao that we have in the house, and also Dr. Tobias, who is also a psychologist, sports psychologist, and doing amazing work in Rwanda. So we are seeking to transform the sports ground, our dusty field, into a safe space, into a sanctuary of restoration. So if we don't build this pathway now, we are simply waiting for the next preventable tragedy. And this is something that we really need to act up very fast, and we build and come up with the best strategies for our academies and the sports sectors that we have in our community today. So before I introduce our speakers, moderators. I wanted to be tempted to take a 60-minute somatic break or reset, but I'll ask each one of us kindly. We are not like, we are flexible, and we'll be having time to time. We'll be having a bit of the break just to practice what we are preaching. You will be required maybe to go and take a glass of water so that you can reset, you can rejuvenate. Okay. All right. So kindly, if you feel like you are dehydrated and you are thirsty, it's good to take a walk, stretch a bit. You can go to refill your cup. That is accepted. Our panel today, I can see, I'm just looking at the chat, and I'm looking the kind of Tracy Opanga, the kind of people that have joined. I acknowledge, I can see Sylvia, I can see, yeah, without even mentioning the experts that we have today. So you will allow me just to give a bit of story before I welcome our speakers. I normally like to relate the discussion that we are having with the real life situation, because I'm talking from experience. I've walked the journey with these young people in the field. If you check most of my videos and posts, you will see me in the field, more majorly using football and tennis, but also we are exploring even in other sports sector. So I traveled through an estate that was in rural, I think in the rural community, not I think, but it was in the rural community, one of the academies. And I saw kids who ran until they collapsed. There was a lot of energy seeing these young people. They believe that if they just run harder, the poverty and the hunger, the anxiety will eventually lose the race. But we know better. We know that when a child carries the weight of family survival, they are not just running, but they are playing. So we often speak of the African child as a demographic dividend. We don't forget the old proverb which says a child who is not embraced by the village will burn it down to feel its warmth. So right now, in our schools and clubs, we are watching these children burn out, and we are still asking ourselves why the systems is not working, right? So the system is not working because it is fragmented. Let's just be frank. So the coach has the hit, but no clinical roadmap. The doctors, the doctor has the clinical skill, but no access to the pitch. We are operating in silos, and today we are here to speak those silos. We are here to build the club to clinic pathway, the technical plumbing that ensures no child's mental injury goes unnoticed. and no coach is left carrying a burden they were not trained to hold. So, ladies and gentlemen, we have laid the foundation. Now, let's go to the field. We are here for high level jargon. We are not here for high level jargon, whereby we are using the medical terminologies. I strongly believe our speakers and the guests that we have, we will try to use the simplest knowledge possible to enable layman or a coach understand, because coaches normally they understand, they know the languages that are on the field. Yeah. So I'll go straight to our speakers now. It is now a moment to hear from our speakers. And right now we have three speakers with us, and the people who have really followed so keenly to look what they're doing and the impact that they are creating in their field. And to start with our first speaker, whom have a privilege of tracking the work. And last time we missed him during our second virtual roundtable, but today I managed to net him, and he's here with us. Dr. Emmanuel, for some time, I've really loved what you are doing, and as the CEO and the principal investigator of AIDS Health in Nigeria, you really do work in your work is really comfort of a quiet lab, and you work where humanitarian health meets the harsh realities of the field. And your research on community-based, that is mental health and psychological support, has become a technical, massive hospital to start saving lives, and also just need a system. So right now, I want you to picture a coach in northern Nigeria, or maybe north in Kenya, who got 40 boys on a pitch, and is the only father figure some of these kids have. And one morning, he notices that his star midfielder, a boy who usually plays with joy, is dragging his feet, is snapping at his teammates, is withdrawing, and the coach knows something is wrong, but he feels paralyzed. He thinks, I am a doctor. If I ask him what's wrong, and he tells me something terrible, sometimes, if you talk about medical, they think that you're a doctor, and I am not, right? And what he said was somehow a bit challenging. And what I do next was also a bit of something that is really touching, and it encouraged them. But I advised him they really need to consult, and they really need to be equipped with the necessary knowledge needed so that they guide these young people. So if you analyze a bit of these coaches, they don't have even first aid, anything, mental health first aid skills that can really help them in checking on a bit of the cases that they have. And they even don't know what they can do, the referral procedures. And this brings me to the question that I have for you today, Dr. Emmanuel. So drawing from your immense as a principal investigator in humanitarian health, where resources are often scarce, I want to ask you, how can we technically design a simple screen, a non-clinical, evidence-based red flag and checklist that allows a grassroots coach to identify psychological distress, like trauma, burnout during training, without him feeling like he has to play the role of a psychiatrist? I know you have a presentation. And again, during your presentation also, we would like you to respond about in these resource limited settings, how can we apply the WHO model to certify coaches as level 1 surveillance partners, and also ensuring that the data they collect is actually clinical, ready for your team at Aid Health to execute seamless triage. The floor is yours. While you still give me some time to project your work, just introduce yourself so people, the experts that we have in the house, can know you better. Over to you, Dr. Emmanuel.
Yeah, many thanks, and I most appreciate your team of experts and technical board for taking this topic up, to kind of bridge the gap, in some of the challenges, that youths are faced with these days. And we are looking to more of this non-clinical approach, to provide solutions to our prevailing condition and situation, especially, in Africa, especially, rural communities where we do quite a lot of work. And these are areas, where resources, are quite limited. So this is just by way of presenting myself. I remain, your presenter for on this topic. By name, Emmanuel Jadvara Musa. I started, my journey quite early in life, around the age of 23, where I developed passion, for humanitarian activities, seeing doctors, going, to rural communities and providing services, especially in the context of missionary, activities, in rural communities. So Aid Health was founded around 2007, by a team of experts, and registered as a corporate entity in 2025. And the research work, has been ongoing, where we develop, policies, and provide solutions with focus in communities, that either hard to reach, or does not have a government presence. So this is just a little, that I could say about this, so that I will not take much of our time for today. Yeah, so talking about this topic, what we will be covering, on this topic, the protection gap, the public health rationale, the simple screening, tax share, and mental health gaps, and then the referral. Next slide, please. Yeah, so on the referral failure, what are those key things and components, that fail during referral activities? Looking at the protection, closing the protection gap, most essential, is the surveillance vacuum, where coaches are often, considered, being the first to notice burnout, and anxiety or trauma, but we have seen, that they lack, a clinical roadmap, to act on it. On the second reason, is the system, overload. This is quite seen, in many resource-limited health settings, where, health care, professionals, treat sports, as an outsider, event, or sector, which is considered a fragmenting, health context. The third one, is the referral, disconnect. Without a formal SOP, without, getting, the roadmap, it is hardly an individual, to have an identification, of those collapses, into the drop, of cases, that are supposed, to be identified. So on that note, it is difficult, to follow up, and you notice, that or realize, that there will not be consent, and then the pathways, like we would have seen or noticed, are defragmented. Yeah, next slide, please. Yeah, so as a spot, in the community surveillance node, to provide, a holistic approach, to this, and then looking at, the WHO, lens, a health system, is not only, as strong as, its reach. So the WHO, health system approach, to building blocks, service delivery, workforce, information, is seen not to stop, at the clinical gate. They should extend, into community structures, where people already gathered. Like we would see, on the right-hand side, where the WHO, surveillance pyramid, had given us, a clear roadmap to what is essential, in this context. So we could see, together, that grassroots football and sports clubs, are, the primary social, ecosystem for, especially, the youths, and it is an existing, trusted point, for the coming together, of communities, different, tribal settings, and social, well, I would say, it's a social gathering, sort of. Community-based surveillance, being the logic, behind community health workers, is a network, and IDSR, shows, that trained lay observers, extend, clinical reach, without replacing, the clinician. So with having the CHW, adequately trained, we are not trying to say, that the clinicians, should be put out of view, but they have, a role to play as well. On our third point, the dusty pitch, where, these events, takes place, can function, as a recognizable, public health sanctuary, a first tier, of detection, feeding a formal referral system. So, like I earlier said, the referral surveillance, the surveillance pyramid, as we can see, would start, with the community, and then the pitch where every, athlete, is present, and then the training sessions, and then also those, that are, the sport viewers, are all present. Then the second layer to that, is the first level, surveillance partner, which are, the certified, coaches, that provide, the simple of the simplest, screening to the primary, healthcare facilities, whom are going to do the basic, sorry, pardon, please, are going to do the basic triaging, and treatment, for those cases. In a situation where we have compounded or complex cases, the tertiary, level, where clinical care, is presented, is provided rather, we have, the psychiatrists, and clinical psychologists whom are, there, to provide the holistic clinical services, to those clients. Next slide, please. Next slide. Yeah, so on the basis for tax sharing, we are going to now look at the lens of the WHO mental health, gap tool. The WHO mental gap action program, is essential, with providing the normative rationale for extending detection and the first responding tax, to train non-specialists, in resource limited settings. This same logic, applied, here, for coaches. We can see them, in a group 4, which start with the scale, scaling the gap. This essentially, addresses the shortage of specialists, in mental health workforce, that are relevant or relative to population need, or acute in fragile and humanitarian setting. On the second pillar, we have, the tax shifting, and the tax sharing. This is a structured delegation of defined detection and support tax, to train, to supervise non-special specialist cadre, to never diagnose, but rather, to triage, the situation, which now shift, to the standardized protocol being, the third pillar, which echoed by simplifying, to validate decision tools, in a non-clinical approach, that can apply, consistently, with a clear escalation, pathways, to triggers. On the last pillar, we have, the supervised linkages, where every non-specialist, tier, reports upward, into the supervising clinical structure, being the principal approach, to sessions, calls, tailored to the SOP. Next slide, please. So this is to give us, a very simple approach, to screen, being the design approach, for the WHO method, being the non-clinical evidence-based, red flag checks or checklist, without stepping, into diagnosis. We have the clinicians, we have the psychologists, we have, the specialists, that are there. But looking at the non-clinical approach, the first on the list, is the behavioral, non-diagnostic, approach, which instruct us, to itemize and describe, observable behaviors, a coach can see, in training or at training, and it is not expected, that you diagnose, but no, symptoms, required, or a clinical interpretation, to be provided, at this stage. Followed by the second stage, which is, just the short, and binary approach. This is a 5 to 8, items, of or no or yes, checklist, that can be completed, under 2 minutes, complexities, defeats grassroots approach, adoption. So you can have, a non-clinical person, on this, approach, to just, strike, either yes or no, to fill, the checklist of 8, itemized items there. On the tab list, we have one clear threshold. This indicates any single red flag or a defined cluster triggers, could trigger, one action. That would mean, to escalate, but never a coach's own clinical judgment, for a call. And further on the list, is the bounded scope, of practice. This tells us, that the tool states what it is not. That is not a diagnosis, nor a treatment plan, not a substitution for clinical assessment. Thank you. Next slide. Yeah, so on the simple screening, we have, based on this WHO lens, we have the 3 observable domains. These domains are 3, in number: the trauma, the burnout, and the anxiety. So the observable domains, on trauma entails, that one, is marked change in participation, rather, flinching at contact, avoidance of specific drills or teammates, and sudden withdrawal. So these are the observable indicators, that a coach, should observe, at this level, of trauma. What is not expected, to be done or attempted, is naming a cause or event, or asking the athlete, to recount it. On the burnout domain, the observable indicator there, entails, that persistent fatigue despite rest, declining performance, loss of enjoyment, irritability over 2 or more weeks, should be observed, by the coach. And what the coach at this level should not attempt, is to distinguishing, burnout, from depression clinically, because this is, the main role and responsibility, of, a specialist clinician. Third on the list, of this domain, is anxiety. And on this list, a coach, is expected, to visibly, pre-session distress, repeated physical complaints without injury, avoidance of competition settings by the coach. So the coach at this level is expected not to be prescribing coping strategies or medications, to an individual, rather, guidance. Next on the list, next slide, please. Yeah, so operationalizing this task sharing, being our next slide, is in the context of applying, the WHO mental health gap, being a model, to certify coach at level 1 surveillance, or as a level 1 surveillance partner. We have classified them, into 4 groups, which is the level 0, level 1, level 2, and level 3. On the level 0, we have the community and the coach. This is, where the sport activity, takes place. So it is expected, that this applies, the simple screening. The simple screening is applied, at this stage. documentation and escalations are made only. Moving to level 1, where we have, the certified surveillance partner. At this level, being a coach, it is expected, that a brief of the mental health gap, alignment training, is instituted, structured, hands off, with a minimum data set, is applied. On level 2, where we have the primary healthcare, worker, at the health facility, they receives, referral. They conduct the first clinical triage, to identify, the cases using, the mental health gap tool and decision protocol. While on the level 3, where we have, the specialist clinician, where diagnosis, treatment, and supervisory oversight back down the chain. Where this is a level where, complicated cases, are being managed by a specialist, going through all the tools that have been presented. Next slide, please. Yeah, so on the certification pathways, being a responder, there are, a couple of itemized block of considerations, that need to be, in place. One on the list, is the training, second, certify, third, to equip, and then 4, supervise and renew. So this can never be overemphasized, as being a clinical or non-clinical specialist, wherever we find ourselves, to work, in resource limited settings. On the first level, it is expected, that certification pathways, will start with training. Short structured module, on simple screening, will be conducted, scope of practice, that boundaries around, mental health, and referral SOPs, in detail, should be provided, to the participants. Not generally mental health, theory, and also on the level 2, certification checklist, non-academic exams, at this level, correct application of the checklist, should be administered. And correct escalation decision on case vignettes. On the equipment or equipping, standardization, documentation tools, and paperworks, tailored to those SOPs, should be provided, producing a minimum clinical readiness data set on every escalation. Like I said earlier, we have them, 5 to 8, in number. This provides the renew stage, where, clinical supervisors at this stage, at the facility, health facility, should be identified for referral purposes, periodic case review as the case demanded. Next slide. So on this slide, we have the trigger, to treatment SOP. We have a category of them, here, total of 6 in number. This is the clinical, technical spine linking a coach's observation, to a clinician's intervention. This is the referral blueprints, that identified in different codified sessions. We have the trigger, we have the document or documentation, we have the consent, we have the refer, triage, and follow. On the coach domain, we can see, that his work, are grouped, in only two domains or only two pillars, which is the trigger and then the documentation. So it is expected, that the coach observe red flags via simple screening, of the 5 to 8 questions, and the second, is to provide documentation of minimum data sets, that are recorded, dated, and his signs. While on the clinical domain, we have the consent, the refer, the triage, and the follow-up. So parent guardian notification, must be obtained, before referral, is provided. While referrals, are made, at the referral stage, structured hands-off, to link clinical or clinic considerations are made, followed by the triage, to a clinicians, and then the outcome looped back, to a club, that is made on confidentiality purposes. Next slide. On this slide, we will be seeing, the clinicians' readiness, in making the coach data, relevant. And we have a couple of them, as outlined here. Let me read. A referral only function if the receiving clinician can act on it immediately when it is made without re-interviewing the coach at that stage. The minimum data set, is the standard tool, that standardizes what travels, with every escalation, along the path. So we have, as outlined there, the athlete identifier, and age. We have the screening result, the observation window, the consent, status, whether consent, is provided or not, the coach's certification ID, and then the urgency flag. Next slide. So, like we said, talking about ethics, consent, is more essential, to a child, and safeguarding purposes, being the reason, that at any point in time, cases, can be withdrawn or disagreed upon when presented. So the best practices, there as a governing, protocol, is at the best interest of the child being the first focus. So every referral decision is evaluated against, child's protection standard, not sporting outcomes. Okay. So is there consent provided, by the parent? This is non-clinical hands-off procedure. Without documented guidance or parent, consent, exceptions, eminent, risks, is exceptionally, defined in the SOP. So the SOP, is our guiding, basis, for every decision, that is taken at that level. We on data minimization, coaches, transmit, the minimum data sets only, never full narratives, or diagnosis or speculative labels. Confidentiality across, the hands-off. It is expected that structural SOPs between clubs and clinical define exactly who may access referral data, such as, the clinician, and governing body, and for how long. Next slide. So on the Best practices, that we practice at EdHealth, anchors, this design, and it is a simple screen, and task sharing architect, that we propose, and that it has been, a workable theoretical approach for us. This extend, a surveillance and referral logic already practiced, for humanitarian or in a humanitarian setting. It is first has to be, tested. Community-based health surveillance and formative research design across northern Nigeria, has stakeholders, buy in, for the purpose, of transparency and accountability. On the clinical community bridging, it is a direct experience, linking community level identification to facility base, which is in the best interest, of the client, whom respond within a fragile health system. Rigorous, evaluation culture. We track, such records, in a structured monitoring evaluation, approach, and frameworks which apply basically, to the community health intervention that are provided, in those settings, which is acceptable and acceptable, and in a transparent, approach, because people in the community, like I said, must have a buy-in into your approach. Next slide. So from this session, to November Summit, so what do we hope to achieve? The referral blueprint, being a technical SOP document detailing how clubs formally linked to healthcare providers, is one of the essential key aspects, that we have to develop and make sure, is operational. The responder certification, coaches, need to be trained, and empowered, the knowledge, of every level of what to do, where to do it, how to do it, and what next to do, being a decision tree, is essential in the success, of this approach. Well, on the summit ratification, this SOP, forms the clinical annex, to Pan-African Safe Sport Charter, especially, the Nairobi, November 2026, convention or summit. Why this matters for policy and funding? It is essential, for operationalizing referral answers and data and return on investment questions, raised by investors, turning mental health, in sport from a nebulous idea, into a measurable health intervention that ministries and development agencies can fund with confidence. Next slide. Triaging begins on the pitch, not just the hospital. So not like the normal practice, that a client, from the pitch will just jump, to the health facility, to present with a case. But this summit and approach will give us, a path, that is a functional, operational, and, organized. One of which, is what is the minimal clinical governance does a club need before it can safely operate, at level 1 surveillance partner? So these are some of the questions, that we should ask ourselves, at this stage. How do we pilot and evaluate, a simple, screen before it is written, into a safe sport charter? Like I said, earlier, going back, to the community, to doing, identifying, with conducting, stakeholder mapping, identifying, with your stakeholder, presenting, what is expected, of the event, what the stakeholders, are also expected, to deliver, so all hands must be on deck. Who owns supervisory accountability when a coach referral, is missed or delayed? So we can see here, that everyone, is expected, to play a role in making this a success. Next slide. Thank you for listening, and God bless you.
Thank you so much, Doctor. That was an amazing, quite informative, Dr. Emmanuel. We really appreciate that. And I know we may be having questions, and I advise the delegates kindly make good use of the chat for the time being, because I know we still have some time for Q&A, but I encourage you to type in your questions so that Dr. Emmanuel can start responding to them. And it's really touching if I saw on how you've broken that down, and you've hit on the essence of task sharing to mean that every sector really needs to take responsibility, starting from the coaches, starting from the parents at home, and then going all the way to the hospital. And I like when you said triaging starts immediately in the field. And there was something just clicked my mind, is the issue of data privacy, because this is something that even coaches are still not do not know how on how they can handle it. But I strongly believe with stakeholders coming together and building the capacity of the coaches, they'll be able now to comply, so that they are not on the bad side of the law. And again, you are essentially telling us that the coach needs to be an intelligence officer to the clinic. That's very amazing, not a psychiatrist. That's amazing. And thank you for that. I'll just request you don't drop off. Just be around, because I know we have questions for you. So I encourage every one of us to type in something. So before I go to the next speaker, I'll just like to upload to. I can see the chat. I can see different people. I can see that is Osimbo from PMWC. And I can see Tracy Opanga from Stada, Kenya. We recognize your presence, and we really appreciate you joining and being with us today. Your contribution will for sure shift the narrative of wellness in sports. So at this time, allow me to go to the next speaker. Okay, the next speaker. So our next speaker is Dr. Jackson Shower. So Dr. Shower is a medical doctor and also a psychiatry, registered with the Ministry of Health in Zambia. And so when you look at the landscape of African public health, you see that we often treat sports as a hobby and health as a clinical mandate, and never the two shall meet. And Dr. Shower is one of those rare leaders who understands that we must harmonize these two words if we are to achieve a true healthy security. So like I said, I like stories, but let's look at the financial reality of our athletes. And I've sat in rooms with health planners where we discuss hospital bed capacity, malaria funding, and maternal health. The other time when we were hit by um, COVID-19. So these are critical, but I've rarely had a conversation of those high-level policy meetings about the mental health bill of a grassroots sports club. Even though we've started talking about mental health and on how we can scale up funding on mental health, but also, I'll really be more than glad to hear the mentioning about sports as an entity. And again, I also happened to meet a mother in Kenya, and this even happens in Lusaka, I am very sure. And this mother, whose son was in an academy football. Is an academy footballer, and the son ended up in a psychiatric ward because he felt he had failed his family after an injury, and the family's life savings were drained in 3 weeks of inpatient care. You know how mental health services are very expensive in terms of the drugs in some cases, but right now the government is trying to, as much as possible, to come in with some resources to ensure that we can reach them. The services they can be accessible and also affordable, and that is not just a medical trajectory. I think it is a policy failure. We spent zero on his mental resilience during his training. So that's something that we really, when Dr. Emmanuel mentioned, our coaches really needs to be equipped with this mental health first aid so that they can be the first responder to identify these cases at grassroots level. And also we spent a fortune on his clinical collapse. So I'll mention that is not a cost invisible line items, but we are currently paying for the collapse, not the foundation. So, Dr. Sawa, just to come to your question, you are in an engine room of national policy, and you see the gaps where the systems leak. And my first question will come to straight if we are to honor the Africa CDC mandate that mental health is a hospital or a health security issue, sorry for hospital. How do we present the economic case to our national health ministries? And how do we convince the Treasury that funding sports-based intervention it's a preventative strategy that can significantly lower the national public health burdens over a 5-year cycle? I'll go to your second question again. So I want you just to take your time to exhaust and expound on the questions that you are supposed to respond to. So from your vantage point in the ministry, what is the most realistic standard operating procedures that allows a local sport coach to refer a child to public clinic? We don't want a 50-page document. We want a protocol that a nurse and a coach can agree on by the next Monday, if possible. And as we prepare the Safe Sport Charter for the upcoming November and something that we can use in our grassroots sports sectors, what policy language do we need to include to ensure that mental health support becomes a mandatory accreditation standards for sports club to remain in operations? Over to you, Dr.
Thank you very much. Thank you very much. And thank you, Dr. Emmanuel. That was a good presentation, and you really took some things away from me. So I think mine will be briefer than yours because you already mentioned some of the things that I will mention, but I'll go through some of the most important things. And just to send my apologies, I don't have a PowerPoint presentation myself. Due to communication, and I was in the field, we were collecting some data, some WHO data on essential medical lists for drugs for neurology and mental health as well. So just to introduce myself, maybe before I start, I'm Dr. Jackson Shawa. I'm a psychiatric registrar, a medical doctor by profession in Lusaka, Zambia. I'm working with currently with Chainama Hills College Hospital, which is the national mental health facility that we have in the country. And aside from that, my clinical work, I'm also part of a youth-led non-governmental organization where we deal mostly with health education and persons with disabilities. And when we currently have a running grant with Plan International where we deal mostly with safeguarding. And it's good that I saw Dr. Emmanuel mention safeguarding. So that also is something that I'm really also very much interested in myself. So just to start with, I'd like to, I know the poster says I'm from the Ministry of Health, but just to raise a disclaimer that I'm not giving an official government position myself, but this is just to speak from the Ministry of Health experience that I've had and the practical service delivery perspective that I have as well. Okay, so for me, the key message is very simple. Okay, so sports-based mental health should not be treated as a side activity like mostly it's done. It should be treated as an early warning and a prevention platform for young people. Okay, so like Dr. Emmanuel said, the coaches, the clubs, the academics, be it the physical education teachers, they often see the young people regularly more than we do. And in this busy world, mostly you find they're the ones that are mostly with the children than ourselves, the parents. So they are the ones that are spending most of the time with the children, with most of our relatives. And they are the ones who might even be the first people to notice the change, the early change in these young people, be it them becoming withdrawn from the training. You find someone is not interested. Okay, they can become unusually aggressive, they can become anxious, they become hopeless. All of a sudden, someone doesn't want to pursue the sport anymore. Okay, they can start using substances as well, sometimes to enhance their activity as well. Or they can suddenly start dropping in their performance, and the coach can notice that, okay, this one was a really promising talent, but what is happening now? So if we build a safe pathway from the club to the clinic, then the sport becomes more than recreation. It becomes something that they can take up as a career as well. Then it becomes part of the community mental health protection. So starting with your first question, when it comes to budget, so budgeting for resilience, it's really a tough topic. Um, for most of us, I'm sure, being in Africa, being a global village, we understand how most of our ministries are struggling already with limited staff, be it limited medicine, being overcrowded clinics, the growing mental health needs. And we know that most of us, if I look at the mental health um, action gap, and if I look at the mental health data that we have in Africa, when you look at the staff, the human resource that we have, it's really very low already. So already we have a growing mental health need, and we don't have a lot of mental health resources as it is. So if we are to convince the health ministries, we must stop presenting sports-based mental health as a new expense, because once we're adding another expense, probably it won't be funded. And they will definitely say, this is not, we are not prioritizing this right now. Obviously, with the budget cuts, most governments are maybe focusing on HIV, focusing on TBs. So if we are presenting it as a new expense, most government might not take it up. Okay, so we should present it as a prevention strategy rather than a new expense, and that reduces the pressure on the health system later on. So if we present it as that, okay, if we come to say, please fund another program, they will definitely not fund it. But we come at this program helps identify distress early. It helps prevent crisis. It reduces school dropout. It reduces substance risk. It reduces self-harm, and it links the young people to the care before the problem becomes severe. Then it becomes a health investment, because we know if we ignore something, a mental health problem, we ignore it early, instead of someone being screened and being treated outpatient from their house, and the government takes them in to treat them in the facility. They have to provide food, they have to provide medicine, they have to provide basically everything. And that becomes more expense to the government. So if you present it as a way of as an investment where it's a public health investment, then it becomes something that most government can get into. Because if you look at the mental health the Abuja Declaration, for example, we agreed, most of African countries signed it and agreed that 15% of the national budget is supposed to go to health. But we see up to now, not many countries have adopted that or have realized that. If I can use my country as an example, 2023 we're doing fine, we're like 11.8%. Then 2024 we kept on dropping until the recent one is at 10.3. In as much as the amount of the money that is allocated to health is increasing, but the percentage of the overall budget is reducing. And if you look at that health budget in itself, the percentage of the money that goes to mental health is very minimal and very negligible, because it's under the non-communicable diseases. And there are a lot of other non-communicable diseases, be it diabetes, hypertension. So you find most of it is going through that direction. So if we say it's coming in as a preventive measure, and it reduces the cost on the spending for the government, then that might be a way that it could be adopted. So if I were to say the budget document, I would build around maybe 3 points that I would mention. Maybe the first one is this is the prevention, like I've mentioned. So prevention, we know, is cheaper to identify anxiety, trauma, be it substance use, being bullying, being abuse, okay, depression itself. So like Dr. Emmanuel said, as the coaches are able to identify this and tap into the referral system that can be made from that, it would be a preventive way of doing things. Okay, so the second one would be this uses an existing community structure. So we need to have we have these structures that are already there in the communities. We have the sports club, we have the schools, we have the academies, we have the community teams already that exist in our communities. So if we say we are not building a new hospital, we're not building a new system, we're just using the already existing community structures that are there, and all we want to do is strengthen the referral system in the identification of these mental health conditions that are there, the mental conditions that are there in the communities, then we can strengthen the bridge between the community itself and the clinic. Okay, and thirdly, this can be integrated into the existing primary care activities. Okay, so it can sit under the mental health promotion. Okay, I'm not sure about other countries, but we do have these mental health promotions in my country, where we go to schools, we go to communities, be it grounds, where people play football, where people play different sports as part of health promotion, mental health promotion. The adolescent health, the school health, the community health, the non-communicable disease prevention, the health education that we do in the communities, be it churches. From there, we integrate that system, and that makes it easier for ministries to budget for it, because it does not need to appear as a completely separate vertical program, but it's already in the existing program, and you just put in this component of sports as well, so that you target this sports club and the like. So as I mentioned earlier, the organization that I'm with, one of the activities that we're doing outside the grant that we have this chess initiative that we're doing with the schools. And what we're doing with that, we're just using chess as a tool as well. So we are using this, and we're training both the teachers and the students and the pupils, so to say, when it comes to mental health. And from there, you can see that they can easily identify when someone is distressed. So we can just use that as a tool rather than using it as a whole different system. So when we go for those mental health promotions, we can now try to see how best they can help with identification. So on this one, on the budget one, my practical recommendation would be that ministry should begin with a small budget line under primary health care for community mental health prevention and referral. Okay, so that budget can cover, coach orientation, the simple screening tools, the referral forms that we are planning on using, the safeguarding training that Dr. Emmanuel talked about, the supervision meetings, and the basic monitoring that we need. Okay, so this message to ministries should be: we are not asking you to fund sports. Okay, we are asking you to fund early detection. We're asking you to fund referral systems. We're asking you to fund the prevention using a sport as an entry point. And this is how we move from a donor-funded activity maybe to a routine public health function. And the other way would also not to only burden the Ministry of Health alone, because we know sports In Zambia, we have the Ministry of Sports. I don't know about other African countries, but we have the Ministry of Sports. So, and we know that mental health mostly is cross-cutting. It cross-cuts almost all the ministries. So in this case, you might have a collaboration with the Ministry of Sports. You might see how they might come in also with the funding, with the health promotion, with the health education, mental health education, and how that can be integrated into that referral system. That way, it would come in as not a new system, but as strengthening the already existing systems and maybe strengthening the referral system that might come about. Then the second question that you mentioned was on practical referrals, about standard operating procedure. So from the Ministry of Health perspective, the referral pathway must be simple enough to work in a real community setting, because we know, like you mentioned, if it's a 50-page document, most likely it won't work. People are too busy to start reading a 50-page document. It's supposed to be something that would be simple. Even if you're orienting people, it's supposed to be something that they would easily understand and something that is practical. In that case, if you're bringing something very new, most likely it will fail. Okay, so the referral must be simple enough to work in the real community setting. If it is too complicated, coaches will not use it, parents will not understand it, and the clinics will not respond. Okay, so I would suggest maybe a 6-7 step standard operating procedure in this one. So the first one, I think most of these, it will just be repetition of what Dr. Emmanuel talked about. The first step would mostly be identification. Okay, in this one, mostly the coaches are the ones that are supposed to be in the forefront, okay, of doing this. The coaches, be it the physical education teachers, okay, they are the ones who are supposed to be in the forefront of this, and they can use the simple red flag checklist that we talked about earlier. Okay, so the coach is not diagnosing, like we discussed, they are not making the diagnosis, but they're using from their judgment and from the training. And maybe before I continue with this, when you look at the coaches, I don't know how many coaches are actually trained in psychological first aid. Okay, because this is a very important component that most of them would need, because it's not psychological first aid doesn't need you to be trained to have a mental health degree, to have a mental health certificate. It's just a way that it's a first aid, the same way we train the physical first aid. Even psychological first aid can also be adopted by many coaches, and from there they can at least help in that emergency setting, even as they're referring different people. So the coaches has a simple red flag checklist. Then they are not diagnosing, then they're only noticing warning signs. From when they see those warning signs, which may include the young person suddenly withdrawing, they might be crying frequently, they might be becoming unusually aggressive with their friends, they might be missing training repeatedly, okay? They might be expressing hopelessness, okay? Signs of depression, they might be talking about death, okay? Signs of suicide, showing signs of abuse as well, okay? And using substances or having a sudden drop in performance and behavior. So that would be the first step. Once they do that identification, they use this checklist. Then the second step would be to immediately safety check. Okay, so if it's in an emergency setting, that's why I said psychological first aid would be enough. If is this child immediately in danger? Okay, if they are in an immediate danger, for example, they're having active suicidal ideations. Okay, that's an immediate danger. Okay. So if they're having that suicide talk, the self-harm talk, the severe violence, the abuse, the sexual assault, for example, the intoxication, okay? If this is a yes, okay, this is not a routine referral anymore, okay? It becomes an emergency, okay? So the child should be taken urgently to the nearest health facility, the emergency service, okay? Police victim support if that is needed in a case of abuse, where appropriate, or child protection services, depending on the situation that the child presents with, okay? So this one also should put in mind that at this point, guardians are also supposed to be involved. So depending on what the child presents with, sometimes the parents might be the perpetrator of that abuse. So in that case, it might be difficult to get consent from the same parent that has been abusing the child. So there you might now need to see what options do you have. Okay. So you go to the next step, maybe the step 3, which is a supportive conversation. So this is where psychological first aid is really very important as well. Okay, if there's no immediate danger, the coach would speak privately and calmly with the young person. Okay, the coach would not interrogate or blame the person, okay, or promise secrecy. Uh, um, okay, they can say things like, I can notice you have not been yourself. I'm concerned about you. I may need to link you to someone who can help. Okay, not presenting yourself as now the healthcare provider. I'm sure Dr. Emmanuel talked about this as well. So you can offer them that help, but not being the one who be the healthcare provider where you reach a point of now giving that, therapeutic intervention. Okay, so this protects the trust that you have while making it clear that safety comes first in that instance. The next step will now be involving the parent or the guardian involvement. Okay, so for minors, definitely we know that the parent or the guardian should usually be informed and involved at every step of this process. If they go to the hospital, most likely they would want to know what your relationship is. If you're the coach, they'd want to know what your relationship is with that child. If you are not the father, most likely would try to ask around, how come you're the one bringing the person here? What about the parents and all that? So make sure that the parents or the guardians are involved in that process, unless in a case where they are the risk factor to the child himself. Okay, so such as abuse or neglect, in that case, you would want to consider first the safety of the child before involving the guardian if they are the perpetrator of that abuse. Okay, so in those cases, the pathway should go through child protection or social welfare structures when the perpetrator might be the guardian or the parent. Then in step 5, where you have now the referral to the clinic, the coach completes a simple one-page referral form. For example, a referral form can be developed, a very simple one, okay, where they can now have this referral form sent, go with the child to the clinic. And one of the things I think for the referral form, the things were highlighted by Dr. Emmanuel, things that would be important for this referral form to have. And it should include the child's name, the age, the guardian's contact, maybe the club name in that case, the main concerns, the red flags noticed. Using the checklist, it can be attached as well. The agency level of it, is it really an emergency? Is it something that might not need admission? Okay. And the name of the referring coach also might be very helpful. Okay. So it should not include unnecessary personal details or things that are not really things that are not yet saying, no, this person is depressed, because that now will be giving someone a diagnosis even before they are reviewed by the healthcare profession. So those things are supposed to be there. And the referral should go to the named local focal point person at the nearest clinic. Okay. If we were to in our Ministry of Health, we have people that we call focal point people. So we have mental health focal point persons, and these are the ones that are usually in charge of most of these mental health, maybe be it in the district, be in the province. They are the ones that are mostly the focal point people when it comes to mental health. Whatever challenges are being faced in mental health, they are mostly the focal point people before they even escalate. So they might be a good point of contact in case of any referral that is needed. Then preferably the mental health focal point person, be it an adolescent health focal point person, be it a psychological counselor, be it a clinical officer, a nurse, a doctor, depending on the local setup, because some of them, the nearest place might be a clinic. So depending on the setup itself. Okay, then the step 6 can be the feedback and the follow-up. So once that person enters the system already that is existing, because once they go to the clinic, they go to the hospital, they have now already gone into a referral system that is already existent. So at that case now, the system might take it up from there. So step 6 might just be feedback and follow-up. Now, from the coach's aspect, okay, the clinic should confirm that the child has been received, but it should not disclose confidential clinical details back to the coach. They can confirm that they've received and they're treating the child, and they can have that. They can be, maybe somewhere where to tear on the paper and say, okay, this part goes back to the coach, and you just report that you've received. Then they can come back with that paper after bringing the child to the facility. Okay, so the coach only needs to know whether the child is safe, whether they can continue the sport, or whether they can temporarily adjustments are needed, or who to contact if concerns continue. Okay, so the SOP itself should be a simple one. Okay, it should notice first thing the field, notice there if anything. Okay, check the safety of the children. Okay, the support, involve the guardian, you refer, and you follow up. Those are mostly the practical steps that are needed mostly in the standard. Coach identifies and supports, and the clinic assesses and treats. Okay, so the coach doesn't assess to give the diagnosis. or treat, but they usually identify and support that child and refer to the next facility. So for this to work, every participating club must know its nearest linked clinic. Okay. Alone, I'm getting some feedback. Am I still audible?
No, no, doctor.
Okay, thank you. So for this to work, every participating club must know at least their nearest linked clinic. You can find we've had some instances where people have, there's a spot, but you find you receive a client and you're asking where they're coming from. They're coming from very far, and you wonder, but you skipped all these levels. What happened? And you find people are not privy of these services in their communities. Okay, so they are supposed to know their nearest linked clinical bit facilities, the focal persons, okay, the referral phone numbers, if possible, and the emergency pathway, how they're supposed to move from one step to the next. Okay, because without that, the referral system will remain theoretical, and you would find someone moving from the field straight to a third level hospital, which would be something that will also stress the system itself. Okay, so looking at the third question that you asked on the national safety standards, okay, if we're looking at the Safe Sports Charter, okay, this question is a bit difficult, but I'll try to tackle it as best as I can. Okay, so for the Safe Sports Charter to become a real national standard, okay, it must move from being a voluntary statement to being part of the club registration renewal. I'm saying this because when you're looking at non-government organization registration, for example, there are documents that they will need you to submit for you to fully register that non-government organization. And this can be the same thing when it comes to club registrations and renewal process. Okay, so the simplest way is to make mental health and safeguarding part of the minimum. Okay, the minimum requirements, okay, for any youth sports club, be it an academy or a school sports program to remain registered. Okay. This does not mean that we're punishing any of the any of the sports club or the academies, but it should be the minimum requirement at least as you are registering. Okay, and this it means setting basic standards that every club can understand and gradually meet at least at the bare minimum. Okay, I would suggest maybe 3 to 5 standards that might be taken into consideration. The first thing should be every club at least should have a written safeguarding and mental well-being policy. As the safeguarding policy, I know for most NGOs, they will definitely need you to have a safeguarding policy. I don't know how the registration process is for the academies, for sports academies and the clubs, youth sports clubs, but a safeguarding policy should be one of the main things that you're supposed to submit, and adding that a mental well-being policy. Once that is put in action, at least they'll know that for the first start, even as they're developing that mental well-being policy, they're supposed to know that mental health is important for this club. Okay. The second thing would be every club should have at least one trained well-being or trained in mental well-being or safeguarding focal person. At least the club should have someone who has been trained. So even as they're starting the operationalization of that academy, be it a youth sports club, someone should be trained, be it in psychological first aid, be it in safeguarding, something in mental well-being as well. So that at least will help, even in emergency situation, they would help to de-escalate the situation even before they refer that particular individual to the nearest facility. Thirdly, you can say every child should have use a simple red flag referral checklist, which we have discussed about. This one, I want to go into details with it. At least that should be part of the things that each academy, each sports club should have. Okay. Again, every club, maybe fourth, I can say every club should have a named referral link with a nearby clinic or recognized health provider. For this one, I remember the time I was just finishing my junior residency. I once received a call from an unknown number, and they just told me, "No, are you Dr. Shah? Or someone gave me your number. There's someone coming. There's a footballer coming to your facility because the nearest facility that we've identified." By that time, I wasn't even practicing mental health yet. But when this particular individual came, it was actually a female football club. So when she came, she I was wondering if it's really physical health that she really wanted at that point, because when she came, her complaint wasn't mostly on the physical health, and it seemed more like she was having a burnout, and there were other stresses that she was facing rather than the physical health itself. And I noticed that there's more to be done, and I saw that more started coming after she went. I saw her. She started referring her friends, and I became like a team doctor without knowing at that point. So I saw that it's really important, because most of them at that point, some were coming with problems that they had a year before presenting to the facility. And most of them is because some are just scared of stigma. Okay, they're just scared of stigma, and some of them might think, okay, if I go to the facility because of this problem, maybe my career might end. Okay, so that is also something that is supposed to be taught to this, even to the people who are participating in the sport themselves. So they're supposed to be taught so that they not stigmatize themselves. Self-stigma is also very real. Okay, so they should have this basic confidential records of referrals and incidences without exposing the child's private medical information as well. So the referral link with a nearby clinic or recognized health provider is very important in this case. Okay, so the enforcement should be practical in this case, and clubs should show evidence of these standards during registration or annual renewal. Because if they don't do that, you can say, okay, we need these documents. It's not outright rejection saying, oh, no, you can't register your club. You can say, okay, this is the checklist that we need you to bring, okay, before you register your club, before you register your academy, before you register this youth sports club that you want to open. You can just provide these few documents, be it safeguarding, be it mental health, well-being. How are you going to approach it? Because if you tell them how you're going to approach it in that document, when they're coming up with that document, in a way, they will know how they're supposed to deal with a situation when they have a mental health challenge. So having those documents as part of the registration process, I feel, would be something that would be very vital. And it also should be something that you're supposed to check every time a club comes for renewal of that license. So sports councils, be it ministries of sports, be it ministries of health, child protection agencies and local authorities can jointly support this charter. Then it can become part of the things that are needed for every club at least to register. Okay, but enforcement in itself, it should not only be a punishment. No, it shouldn't be a punishment. It should be punitive in its sense. Okay, there should also be incentives. Okay, clubs that can comply can receive maybe certification. Okay, public recognition. Okay, eligibility for grants, be it access to tournaments. Okay, coach training opportunities. Okay, and partnership supports as well. So when they say, oh, you meet all these criteria, you have these opportunities as well that can come with it. Okay, so this encourages compliance as well, and without making the process feel like a threat. So it just, at least they will know, okay, once I have these documents, I have also these opportunities that can come with it. Okay, so the self-sports charter, it should therefore be a work like a quality mark. It should be more than just a document, but it should be something that you can say, okay, this club has this charter, and you tick it as a quality mark. Okay, and the club should follow it. Parents should know their children are safer that way. They will be more confident saying, "Oh, my child is going to this club. It is certified and it has these things in order." They would be more confident to take their child there, and they would think they would believe it's safer in that way. Ministries also should know there is a referral pathway. So shouldn't be done in silos where you go and train people, the coaches, you train the coaches, you tell them about the referral system without training the other side of the ministry where the healthcare worker does not know about this referral pathway. And the first time they're receiving the referral, maybe that referral document, most of them will refuse. And we were not aware of this. We only receive referrals from fellow clinics, and you are maybe a sports club. We don't understand how this works. So it should go both ways. Ministry should also know about the referral pathways. So the healthcare workers also should know also on how this referral pathway will be operating. Donors also maybe that might come on board should know the program should know the program is accountable as well. And young people know sport is not only about performance but also about protection. So in that case, they will feel safe as well, even as they're taking part in that sport, whatever it might be. Okay, so in closing, maybe I would say my final message would be sports-based mental health intervention is not only about medicalizing sports, because people might say, oh, now they're bringing the psychiatric medication into sports. Okay, it's not about medicalizing sports. Okay, it is about using sport as a safe doorway into care. Like I said, if we use it as a referral pathway, if we use it as a screening place where we can now identify more mental health conditions, where we can see early warning signs and refer someone to the facilities, then you know it's a better way to approach mental health. We know mental health conditions mostly when caught early, the outcome is usually better than if they become severe. The treatment outcome usually is not as effective. Okay, so this is how we move from the theory to triage. We identify early, we refer safely, we protect confidentiality, and we keep young people connected to care. I will end here. Thank you very much.
Thank you. Thank you so much, Dr. Shawa. That was really informative. Let's give him his flowers. Clap. Kindly, if you can see emojis, just to thank you so much. I really appreciate it. Because what you've said is very, very important. The two departments, the clinic and the sports, really needs to work hand in hand. And I strongly believe in this conversation. This is now a conversation that we really need to take it so fast and have a discussion with the Ministry of Health and now come up with a standard referral document that the coaches are able to use that will not be able to put the children that they deal with in danger. I really appreciate that. Please kindly, because of time, just be at standby because I know we have questions that may come for you immediately after Tobias has presented. Ladies and gentlemen, allow me to go to our third speaker. I know time has gone and we remain with the 21 minutes to 4, but there is a section that is really very important. I'll go straight to Tobias. Tobias is someone that we've learned his work through engaging with him and also his contribution during the roundtables that we've been having. And today he's here with us in a different capacity, just to contribute and share his insights from the experience that he has gathered during his tenure in Kenya while he was a player, and also in Rwanda, where he's working as a sport psychologist. So I'll not go into my stories, but I'll just go straight to your question. Mr. Otieno, you are in I'll call it, you are an architect of a health system, and also you understand the frictions that happens when a child leaves the pitch and also enters the clinic. And my questions to you, in our grassroots sports and clubs setups, the coach is often the biggest influencer, but the psychologist is the stranger. I'll call it so in quotes. What specific structural MOUs are required between grassroots academies and private clinics to ensure the referral is not just a piece of paper, but a hand of trust? Because remember, Dr. Shawa mentioned, if it is a document, it's a document that really needs the clinics that the coaches will be referring their athletes. They needs to be aware of where this document is coming from. But also then there is need for attachment and an MOU signed between the entities so that there is clear pathway on what to do, the kind of data to collect, and the kind of maybe information that they can share in this document. My second question will also touch on the confidentiality. We have a major challenge in our community today, whereby people talk, how do we safeguard? That is touching on the safeguarding, which our two speakers have mentioned, an athlete medical and psychological confidentiality during their transition from the pitch to the clinic, especially in communities where everyone knows everyone. How do we ensure that referral for a mental health does not become the gossip of the local football field? And my last question will be, as a practitioner who understand the Ubuntu spirit, I am because we are, how do we educate our coaches to facilitate the first meeting? For example, how do we ensure the athlete understand that walking into your office is a high performance drill, not a sign that their career is over? Over to you, Mr. Tobias.
Yeah, so thank you so much. Hope everyone can hear me.
Yes,
name is
yes, go
Tobias
ahead.
Otieno. My name is Tobias Omondi Otieno. I'm a clinical psychologist and also specializing in sports psychology. Currently based in Kigali, Rwanda, working for a private institution called Solid Minds. And I'm very happy to be here and to be part of this conversation. I don't know if I can have access to share a slide presentation. Yeah.
Yes, please go ahead.
So just a minute. I don't know. Can you see my screen?
That's dropped. Initially, it was loading. Kindly try again.
I will try again.
Mr. Omondi,
Yes.
I'm not seeing your screen yet.
Okay, just a minute.
All right.
Yeah,
Is it visible?
it's
Yep,
visible.
yep,
I
yep.
put it in a presenter mode, a presentation mode.
Okay.
Good. Go ahead. Thank you.
Yeah. Thank you. Thank you so much. So thank you so much for the invitation. This is a very, very important conversation. So this is me in a nutshell. I'm a clinical psychologist. I specialize in sports psychology. I've worked with elite sports. Currently, or lately, I've worked with the BAL champions, the Basketball Africa League champions, as their team psychologist. And I think this is something that is much needed and a conversation that is very important to have, especially in the sports field. So, why is it important? There are a lot of challenges, issues of anxiety, mood disorders, loss and transition, substance use among the youth in these sports teams. A lot of pressure to perform, aspects of injury. There's the impacts of social media, academic stress and trying to balance, of course, financial pressure and the system gaps, which is one of the major things that we are addressing, system gaps. So as we continue with this presentation, I'd like you to ask yourself, who is the first responder? Yeah, who is the first responder when it comes to helping an athlete to, let's say, for instance, they're experiencing depression or anxiety or a loss. Is it the coach? Is it the teacher? Is it the parent? Is it the doctor? Or is it the psychologist? So this is some of the conversation that we're going to have, and it will help us enlighten and how my experience, I got to work to in a position where I was working with an elite team that representing a whole country, and they were able to take it seriously and, have mental health of the players as a priority. So basically, in a nutshell, mental health in sports can be in 3 phases. Can be in the thriving phase where most things are going well, normal functioning. You can cope easily with any challenges. Then you can be in a phase where you are managing. So little challenges here and there, but you can cope in a healthy way. And then there can be the aspect of another phase where someone is struggling. They're not performing as much as they used to. They're missing training. They don't have the initial motivation and such. And then there's the phase where there's the illness. This one, there's significant difficulty in thinking, managing emotions, almost zero performance, withdrawing from teammates, suicidal ideations, and more of that as you can see in the screen. So we want to move from a reactive treatment of mental health challenges to proactive management of the entire continuum. So, and that's why such conversations are important. The referral pathways. Where do I start? Where do I go? Who is involved? And I was really liking the discussion from the 2 doctors who have spoken before me. And some of the unique challenges that the youth experience, but not limited to this. Of course, there's pressure in the game, performance, balancing with school, issues of bullying and self-esteem. Such things are things that athletes undergo here and then. And these are some of the things that need to be addressed. How do you recognize the warning signs? So you can see if it's emotional, you can check on the mood swings, irritability, persistence, and sadness. Physical, players are fatigued, they're not sleeping well, injuries, unexplained aches, such stuff. And of course, performance, both on and off the pitch, can drop. And also social withdrawal from team isolation. So these are some but the basics that every stakeholder should be knowing or should at least have some sort of awareness of. If you're in the field of sports, these are some of the basics that you need to understand so that in the event of a crisis or an issue, you can be able to spot it and at least go through the necessary channels that we'll talk about so that the player can receive help. So there's the aspect of suicidal thoughts or plans, self-harm behaviors, disclosure of abuse, physical or sexual, severe violence or threats, psychosis. This means that's loss of touch with reality. So these are some of the things when you see, you should be able to know that there's an issue that the athlete is going through. And you don't have to necessarily be a psychologist or a counselor to be able to to address or notice such signs. And we'll talk more about that in a few. So what happens when you do not see these things or when these things go unnoticed? Poor performance, overtraining and burnout, substance use mostly as a way of coping, and also recurrent injuries. And of course, school dropouts, when untreated, it reaches to the point of clinical anxiety or depression. There's the aspect of social withdrawal, self-harm, and maybe suicide risk could be some of the impacts if the warning signs are not seen or addressed. So coaches cannot do everything. However, I think the previous speaker spoke something very important about psychological first aid. And that is something also that like Solid Mind Counseling Clinic, we do train people on psychological first aid. And even if you're a coach, there's no harm in you having some basic training and being certified as someone who can do psychological first aid. So a coach is not a therapist, they are not a psychiatrist, and they are not a counselor. However, they can be trained in psychological first aid so that they can be able to spot, respond with empathy, and in the end, refer to an expert, that is a psychologist or a psychiatrist. Yeah. So defining the pathway. a structured process that connects athletes with the right support provided by the right person at the right time. That's what is needed. We need a structured process that connects athletes with the right support provided by the right person at the right time. These systems or processes lack very much, especially in, of course, in our country, Kenya, and something new in many African countries. There's no clear definitions of referral pathways that can help players. And why does it matter? If you have a very clear referral pathway, we are able to intervene at a very early stage, right? If there's a problem, we are able to intervene early. And then consistency, ensuring every athlete receive the same level of care. Why? Because there's a clear referral pathway. From here, the coach knows I should do this, and the person that is referred to knows that what they should do. And then there's shared responsibility, so reducing the burden on individual coaches or teachers. Coaches cannot do everything. Coaches are there to coach. Psychologists are there to do their role. Physiotherapists are there to do their role. Psychiatrists are there to. So everyone has their own job that they specialize in. We don't have to burden one person with all such responsibilities. And then why another important is, of course, protecting the organization through due diligence, right? So the system's voice. So moving from individuals to network. Mental health is everyone's responsibility, but treatment is the responsibility of a trained professional. That's why even as we train coaches on psychological first aid, there still are psychologists and other professionals that know their parts that the coach just refer, and then the psychologist takes it from there. So these are some of the things that should be in the systems of a team from the basic level. When you register a team, just as the doctor had mentioned, these are some of the things that should be like basic, embedded in the team's culture and core. So for an athlete, this is what some might have, other teams might not have, but this is just they are at the center of the coaches, the medical team, parents, school, safeguarding team, psychologists. Yeah. So it's a full system that surrounds an athlete. But what happens most of the time in African countries, one person plays all those roles by themselves. The physio is still the psychologist. The coach is still the physiotherapist. And it doesn't work like that. It is not effective. And that's why I believe this conversation and creating such awareness is very important. So the system forms a protective cocoon around the athletes. So communication is multidirectional. Information flows through the set channels, and the athlete is not confused to navigate the system. So it's easy for the athlete. So just a brief summary of what some of the stakeholders can do, but not limited. So for example, a coach can notice the behavior changes. They are in a very good position to notice if an athlete is struggling in one way or the other. And then they'll provide initial supportive conversation. And after that, you refer to who? To a psychologist. But what happens most of the time, there are no psychologists even in the system. They don't even know. They're not even aware, right? Teachers, academic support, monitoring school-based stressors, and in the end, refer in the event there are mental health issues because they have not specialized in that specifically. Parents, informed consent, and then supporting home environment and also refer. Yeah. Psychologists, now they can do the assessment. When athletes are brought to the psychologist, you can assess what are the mental health challenges, therapy that can be done, and also return to sport planning. And also safeguarding lead. So for risk assessment, documentation, and policy compliance, which is something that lacks in most of our African teams. So this is just a concept of how the referral process looks like. So at the very beginning, we have observation of signs, and then you have a supportive chat, risk, you assess the risk and need, and then you connect to a professional. And in the end, you check in and monitor. So this referral process also, it embodies what happens in psychological first aid. These are some of the things that are done. So there are different levels to this. Now, at the first level, there's self-help and peer support. Level 2, we have coach and mentor support. Level 3, there's a school counselor. Level 4, psychologist. And in the end, if things are thick or severe, you can refer them to hospitals, right? So standard operation procedures. Standard operating procedures and why every organization needs them. So without this, people will depend on memory only and goodwill. But with SOPs in place, referrals are made from a formal channel, and it's an institutional duty to, like, it's a natural thing for people to address mental health. So they protect the athletes falling through cracks and protect the staff from liability, right? So basics, these are some of the basics that an SOP should include. So the process elements, reporting channels, documentation templates, risk assessment tools, emergency contacts, confidentiality rules, which we'll talk more about in a bit, escalation procedures, consent protocols, and follow-up timelines. Yeah. So emergency contacts in the event something wrong, someone collapses, what happens then in the team? Yeah. So these are just some of the basics that most of the teams lack, and these are things that should be taken very seriously. Why does documentation matter? Yeah. If it is not written most of the time, people will assume that it did not happen. This is why documentation is very important. So what do you document? Dates and time of the concern. Why? It establishes the timeline for intervention. So another thing, observer behavior. Why? To get the objective facts and not subjective judgment. You don't assume or rely on your memory alone. Document the action taken. Why? Evidence of duty of care. And also document referral destination so that you can track the athlete's pathway. So, confidentiality is not a barrier to safety. It is the bridge that allows athletes to cross over into professional care. And trust me, confidentiality among professionals is it's a requirement, is non-negotiable. However, there are limits to confidentiality, especially when there's a risk of harm to self or others. So if someone risk harming themselves or harming others, this is one of the situations whereby confidentiality can be broken. Child abuse, so you have to report even if you're a professional, and maybe they told you that, I don't share this, but if abuse is going on, you need to at least report to a child agency to at least work on that. Public safety, so risk of violence to others. These are just examples where confidentiality can be breached. But other than this, medical emergencies and legal obligation. Other than this, confidentiality is paramount for all professionals. Institutional partnerships and why it's important. And I'm happy because Collins and YDP, they're doing a great job, trying to collaborate with as many partners as possible to provide the best for the athletes. Yeah, so it is very important to connect to schools, hospitals, and federation. So from my experience, solid minds is a private institution, as I said. We have a multidisciplinary team. We have clinical psychologists, we have speech therapists, we have occupational therapists. But what happened is that and also sports psychologists. What happened is that we reach out to institutions, sports teams, and propose ideas. We come to an agreement, and we tend to work together to provide the best results for the athletes. So the challenge is that some of these ideas are foreign to many people. That's why there is a lot of need for awareness. But in the event you find people who are receptive, you end up producing a good product and a good result for everyone, and everyone benefits, including the athletes. Yeah. So clinical reach, you are able to reach many people when you do partnerships, psychologists and child protection agencies. So when there's an issue, it is very easy for you to get access. Yeah. And also aligning with government and NGO policies. These are some of the advantages that comes through when you do partnership, strategic partnerships. So, for example, I'll give a short case study about a teenage footballer has anxiety after an ACL injury. These are things that are very common in athletes. Get injured, then there's anxiety or fear to come back, or when you come back, you're still afraid. So what are some of the things that can be done? So in identification, physiotherapists notice an athlete is tearful and missing gym session. Referral pathways. The pathway triggers a session with a sports psychologist. When they go to a sports psychologist, what happens? Treatment is done. For example, CBT for performance anxiety specific. And then gradual reintegration into the team with psychological monitoring. Yeah. So in a team, you have multiple disciplines, and everyone has their role. And in that, the referral pathway becomes very smooth and very efficient, whereby the athlete safety is catered for at the earliest stage. Barriers and challenges, and the ones that are common in Africa. The cultural stigma, of course, seeing mental health as weakness, a limited number of psychologists and sports psychologists, and not only psychologists, the idea of not utilizing because psychologists are many, but people don't see the need of using them. Why? Because they lack awareness most of the time, and of course, inadequate funding and welfare. So when it comes to structural gaps, of course, poor connectivity in rural areas, people don't have any idea about what mental health is. Yeah, lack of formal SOPs in community clubs, and these are some of the basics that should be happening. Yeah. Also fragmented healthcare systems. So people can't access, there's no clear coordination, too much unprofessionalism and such stuff. So what are some of the practical solutions? Capacity building, and I know Doctor mentioned some of these. Capacity building, training coaches and mental health, in mental health first aid. This is very important. Directories, creating a regional referral map for professionals. Also, regular screening and educational workshops will be very important. And SOP, so providing plug and play policies for clubs. Each club should be having a mental health policy. Like it should be like a basic thing. But is it the case? No, in most countries and African teams. So telehealth, using digital platforms for remote athletes. I'm happy we can connect, from every part of the world. And also normalizing help-seeking behavior to all levels. So this is just a checklist that you can check with the organization or the teams that you work with. Are they there, or do they lack? For example, if they have a written SOP wherever you work or the team that you affiliate with. Yeah. Are there updated referral contacts directory? Maybe there were contacts before. Have you updated? Or do they even exist? Yeah. So there needs to be also defined emergency protocols, staff safeguarding training, very important. Yeah. And also standard documentation forms. These are some of the things that are very crucial for any team or any serious team that wants to perform. So key takeaways, early identification saves athletic careers and lives. System outperform individuals every single time. So if you have a system that is working, if you have put these basic things into place, if you take time and see the importance of prioritizing mental health and seeing it as serious as also physical health, and integrating it into your system is going to be very uh, uh, helpful to the team and the organization as a whole. Also, partnerships are at the backbone. You need strategic partners. You might not have specific expertise. That's why you partner with the doctors, the psychiatrists, solid minds, different institutions to provide whatever is lacking wherever you are at. So as I finish, I want you to think of these questions. What gaps exist in your organization system? And what are some of the barriers that prevent your athlete from seeking help? And then ask yourself, what is one practical step you as an individual will implement today into this cause? So ideally, I'll leave you with strong athletes need strong systems. It has worked very well in Rwanda. They're starting to take these things very seriously, integrating like a sports psychologist in their team, and just seeing they're just doing the basic things, but very efficiently. Yeah, and I believe most African countries have the capacity to do such great things. It's just that there are no defined systems in place. People are not as serious as they should be, and also the issues of some corruption cases. Such stuff are the things that let us down. But we have the capacity to create a platform for athletes that is actually working, taking care of them both physically and psychologically. Thank you. I hope I've answered your question, Mr. Collins, and thank you so much, guys, for listening.
Thank you so much. Thank you so much, Tobias. And that was really something that, if you can agree with me, oh, sorry for that. Okay, you are supposed to be somewhere here. Okay. Thank you so much. And I really appreciate your presentation and how you have broken it down. It was so clear and spot on, being someone who has been in the space working, and you understand Kenyan way of doing things, and also you've gone in a new environment also in the same sports sector. That is, you've really helped us even to view it differently, and also stakeholders who have dialed in. There is serious need of partnership and also working with the sports sectors to ensuring that the youth that are attached to their programs, wellness are safeguarded, and there are clear referral pathways that we can use to ensure that they are good. So at this point, I don't want to take time. I'm very sorry. Our time have really gone. And just apologizing on behalf of everyone, because it was for the good of each one of us, and the kind of knowledge that has been shared here is really something that really needed some good time, and 2 hours was not even enough. I strongly believe these knowledge and the insights that have been shared, we're gonna put them into good practice, and also it's gonna even shape the discussion that we'll be having in November. But even before November, we'll be having various discussions on safeguarding. Mention it now that we have the clear pathways and what is remaining. We know that we cannot actualize this without available resources. And right now, we are not able to work in silos. I'm talking from experience. When we engage, I'll not mention name, one of the entity. It was government entity, and okay, I'll call it person B, and person B told me, we haven't been working with you so closely. But again, as an organization, you really need to have the clear pathways. You really need to know how can we link the sports with the relevant bodies, especially Ministry of Health, the county government, their health unit. And I understand. I was impressed when Jackson mentioned about their focal point persons within, or persons in Zambia that are taking care of mental health services. And in Kenya, um, we do also have the same strategy, because we also have the focal persons people in Nairobi. So I strongly believe that if we really cope with the systems that are working and share notes with different countries, then to mean in Africa we'll be able to bridge the gap of mental health, and bridge the gap of the challenges of mental health that we are having in sports sectors. And there is quite a need of doing baselines and coming up with the data to support what we are doing, because right now we really need to support and back it up. Then um, it will be able to help entities visualize the scenario, how the situation looks like. And also that will really help us even to align ourselves with the Ministry of Health, Ministry of Sports also, and together with the ministry which are dealing with the children. So they also work in collaboration, not that Ministry of Health work separately with the Ministry of Sports. So that we're gonna, I'll pick one big contribution from Jackson when he mentioned that this should not be as a separate entity of a project, but it should be like a prevention strategy that will enable the government bridge the gap, also reduce the mental health cases that we have, also to destigmatize mental health within Africa. So, ladies and gentlemen, I would like to invite you officially to be part of the summit coming up, and also even if you are interested to speak in our series of virtual roundtables, feel free to reach out to us through the contact provided. Sorry. Okay. You can take a screenshot of that. Then you can reach out to us with more details, because what we are doing, even with the summit which is coming, we are having bespoke kind of engagement. For example, if you are interested in a certain segment, for example, maybe SGBV, and you relate it with mental health. Also, if you are interested in maybe climate change and mental health, we can have a discussion and see on how you can have a side session during that day. So at the end of the day, we have joined hands in ensuring that we safeguard and also protect our sports umbrella and our sports wing. And mark you, this is what people we really need to know. Sports is the only sectors that really runs. It's the only harbor or safe spaces for young people. Tell me, in your home, which is that child which is not attached to a sport? It's close to zero. Every child is attached to the sports. But now the coaches that are dealing with your children really needs to be equipped with the necessary tools so that they safeguard and they protect the children. At this point, I don't have much to say. Ladies and gentlemen, I'll only take this opportunity to thank all our speakers and also thank all the delegates who have joined today, together with our technical experts who are behind the scene. Thank you so much, Stacey. And also, thank you so much to every partner who is working with us this journey. We have a couple of people who have confirmed partnering with us, and very soon we'll be able to display all their logos, so that even if it will mean you also join forces, we'll be more than glad to have you on board. Ladies and gentlemen, at this part, allow me to close officially and announce our next virtual roundtable will be up, and we'll discuss it, and it will be on safeguarding. Thank you and enjoy the rest of your evening. God bless you.
Thank you very much to everyone. Have a good day. Have a good evening.
All right. Bye.
You too, and bye.
Bye.